Good morning. I'm making a presentation about arthroscopic double row repair for large or massive rotator cuff tears. Surgical treatment for large or massive rotator cuff tears generally classified two categories. One includes debridement vertebroplasty, tendon transfer, and arthroplasty for irreparable tears. These procedures can obtain good pain relief, but functional gains depend on patient's condition, and outcomes deteriorate with time. Another treatment is rotator cuff repair, which can surely obtain good pain relief and functional gains. Arthroscopic rotator cuff repair can provide satisfactory clinical outcomes. In the previous reports, however, the range of recurrent tear rate was much wide. The purpose of this study was to analyze clinical and structural outcomes of arthroscopic double row repair for large or massive rotator cuff tears. 37 patients were the subjects of this study, including 10 females and 27 males, whose average age was 63 years old. 28 patients had history of trauma. On types of the tears, large tear was observed in 27 patients and massive tear in 10 patients. Preoperative UCLA shoulder score was 70 points on average. As associated injuries, subscapularis tear was observed in 6 patients, long head of the biceps rupture in 6 patients, and delamination of the torn cuff in 20 patients. Arthroscopic double row repair was performed in the lateral decubitus position using the shoulder distraction system. After evaluation of the tear, capsular release and preparation of the footprint was performed. Metal suture anchors were inserted into the medial and lateral row of the footprint. Then penetrating suture grasper was inserted into the healthy portion of the torn tendon and retrieved the suture of the anchor. The same procedure was repeated and then tied the sutures. Subscapularis tendon tear was also repaired using suture anchors. Margin convergence was performed if necessary. Immobilization using ultrasling was underwent 4 weeks postoperatively. Active motion exercise was started at 6 weeks and muscle exercise at 8 weeks. The clinical outcomes were evaluated on the basis of the UCLA shoulder score, and the structural outcomes were assessed using T2-weighted images of the postoperative MRI. The average follow-up period was 18 months. The average UCLA shoulder score was improved significantly from 70 points preoperatively to 33 points postoperatively. All of the patients obtained satisfactory clinical outcomes at the final follow-up. There was no significant difference between large and massive tears in the postoperative UCLA score. Postoperative MRI revealed no re-tear and sufficient thickness of the repaired cuff in 22 patients, insufficient thickness of the cuff in 5 patients, and recurrent tear in 10 patients. Postoperative UCLA score of the patients with insufficient thickness of the or recurrent tear of the repaired cuff was significantly lower than those of the patients with sufficient thickness. Average age of the patients with insufficient thickness or recurrent tear was statistically older than that of the patients with sufficient thickness. Recurrent tear rate of the patients with a traumatic tear, subscapularis tear, or LHB rupture was significantly higher than that of the patients without them. There was no significant difference between recurrent tear rate of the patients with and without delamination. Some previous reports stated that arthroscopic repair for large or massive tear can obtain satisfactory outcomes in spite of structural failure. They concluded that cuff integrity is no significant effect on clinical outcomes. On the other hand, Harriman and McCann stated that patients with the intact cuff can obtain better function than patients with recurrent tear of the repaired cuff. In this study, patients with recurrent tear had loss of the shoulder motion and motor weakness, same as Harriman and McCann stated. Therefore, Secure healing of the repaired cuff is important to obtain satisfactory functional outcomes. Waltrip and Meyer stated that arthroscopic double roll repair can provide better initial fixation and stability of the footprint contact area than other procedures. And recurrent tear rate of our study was almost the same or less than that of open transossal repair in the previous reports. Therefore, arthroscopic double roll repair is the most reliable procedure to obtain satisfactory structural outcome. However, it's possible to occur recurrent tear although performing definite and tight double roll repair. Some authors pointed out that subscapular tear, muscle atrophy, LHB rupture, and so on may be risk factors of recurrent tear. By our study, older age, a traumatic tear, LHB rupture, and subscapular tear are suggested as risk factors of recurrent tear. To decrease recurrent tear, protect rehabilitation such as long-time immobilization and delay of the start of active motion should be applied to patients with risk factors. Moreover, secure tight repair method or augmentation of the torn cuff should be devised to obtain better structural outcomes. As a conclusion, arthroscopic double roll repair for large or massive tear is a reliable procedure which can obtain satisfactory clinical and structural outcomes. However, the patients with the risk factors of recurrent tear repair method and rehabilitation should be devised to decrease recurrent tear. Thank you for attention.